All right, good morning, everyone. Welcome to Wednesday morning rounds and snowy day. Um, this morning, sorry, just technical thing here. This morning, it's my pleasure to welcome Joanne Joseph. She's one of our cardiology residents. I'm very pleased to say that she'll be joining us in the Echo Lab in July, so we're looking forward to that. And then she's going to go on and do another fellowship in adult congenital heart disease. So she's going to speak with us today about transition of care in the congenital population. So thank you so much for joining us.
Thank you, Dr. Stadnik, for the kind introduction. Good morning, everyone. Thank you for the opportunity to speak to you all on a topic that's near and dear to my heart, which is transition and congenital heart disease. So I'm sure you would all agree that the heart is probably the most resilient and robust organ in the body. The fetal heart is able to beat by 4 weeks, and by 10 weeks, it's fully formed like an adult human. There are hundreds of perfectly timed steps that have to come together to form this amazing organ. So you can all see why it can go wrong 1 in every 100 births, making congenital heart disease the most common congenital abnormality in the world. And this can exist in a spectrum from simple PDAs to complex conotruncal defects. So why should you care about congenital heart disease? Throughout this talk, I hope that I can convince you that patients with congenital heart disease are probably some of the most vulnerable patients in cardiology at risk of adverse outcomes during their illness journey, especially during the transition from pediatric to adult care, and discuss how we can help them. So to do this first, I want you to meet Anna. She's an 18-year-old girl with hypoplastic left heart syndrome and Fontan palliation. She's excited but anxious about transitioning into adult care. So throughout this talk, we'll tackle some of the common challenges and barriers Anna and her healthcare providers will face in the process of transitioning her from pediatric to adult care, and conclude with some of the steps we have taken as a group in Ottawa to help these patients. So the first barrier or challenge in Anna's transition is a common misconception that congenital heart disease is predominantly a pediatric issue, which exists not only among patients but also healthcare providers. However, that's not the case. Thanks to many of the advances in diagnostic and surgical techniques, more than 90% of children with congenital heart disease are surviving into adulthood, compared to only 15% in the 1940s. And globally, especially in high income countries like Canada, there are currently more adults than children. And this acceleration in survival is put into place by the invention of the Blalock-Taussig shunt by Dr. Alfred Blalock and Dr. Helen Taussig in 1944 that allowed the increase in blood flow to the lungs of cyanotic infants. This was a huge breakthrough that was first performed on a 15-month-old girl called Eileen Saxon with tetralogy of Fallot. And then this surgery sort of paved way to many of the other major life-saving surgeries that we know of today, some of them namely the Senning and Mustard, the Fontan, Ross procedures. And then these sort of surgeries culminated into the 3-step Norwood procedure for hypoplastic left heart in 1980s, followed by interventions that we know today which can be performed percutaneously, especially when patients need repeat interventions. This is data from the Swedish National Registry in 2022 that shows that mortality in congenital heart disease has significantly reduced over time, especially if they're born after 1975, when these surgical advancements were taking a rapid growth. It is also notable that 10% of the growing population of congenital heart disease in the adults are actually diagnosed in adulthood, which makes congenital heart disease no longer a disease of only the pediatric world. So who is the face of congenital heart disease? I would say it's not just these, but rather a continuum of a patient's entire lifespan. So coming back to the first barrier or challenge in Anna's journey, which is this misconception that congenital heart disease is predominantly a pediatric issue, I hope that we can overcome it by raising awareness that among our healthcare providers and our patients that it truly is a disease that encompasses a patient's lifespan. So the next sort of barrier or challenge in Anna's journey in transition is the misconception among patients as well as healthcare providers that most patients are actually cured after an intervention for their congenital heart disease. It is true that many of our patients with congenital heart disease go through a period of honeymoon with minimum symptoms and limitations after an intervention. However, this period of quiescence is usually followed by latent surgical complications and comorbidities. And since this period of honeymoon is frequently coincided with the period of transition from moving from pediatric care to adult care, it's actually the period of the highest risk for patients to be lost to follow up with negative outcomes in our congenital heart disease patients. So in the same Swedish National Registry that I showed you, it is evident that despite the decrease in mortality over the past many years among our congenital heart disease patients, when we compare them to the general population, their mortality is still 3 times higher, even when we adjust it to common vascular conditions like diabetes and hypertension. And this increase in mortality is persistent among all patients with congenital heart disease, irrespective of the type of congenital heart disease or congenital lesion that they have, whether this be a simple ASD or a complex corner truncal defect. And the more complex patients tend to have higher mortality. This is a table from the Brompton ACHD group in the UK comparing life expectancy of patients with ACHD to the general population, which I find quite eye-opening. As you can see here, if you take a 20-year-old patient with ASD and you compare them to the general population, their life expectancy is actually comparable to a 25-year-old. So whereas if I take a more complex patient, like a patient with Fontan who's 20 years old, their life expectancy actually is comparable to an average 64-year-old patient. That is a drastic reduction in life expectancy in spite of the advancements in surgical techniques and diagnosis that we've had. So once again, confirming that these patients are at high risk of complications and early death, and that's worse the more complex our patients get. Patients with congenital heart disease are not only at increased risk of complications related to their congenital heart disease, like AFib and heart failure, but they're also at increased risk of developing diabetes, stroke, MI, which is acquired heart disease. In addition, they also have sort of physical complications, arrhythmias, endocarditis, pulmonary hypertension, ventricular dysfunction, you name it. They can have things go wrong with their heart just like anybody else. So acquired disease overlaid with the complex congenital heart disease. And in addition to this, they are also at higher risk of depression, anxiety, language impairment, limited social cognition, worse education attainment, unemployment, delayed progression into adulthood and independent living. So coming back to the barrier in Anna's journey, I hope you and I can overcome this misconception that patients and healthcare providers have about patients being cured from congenital heart disease and sort of break that barrier and raise awareness among patients and healthcare providers that these patients are actually at higher risk of complication, not only related to their congenital heart disease, but also acquired heart disease and mental health challenges, making them some of the most vulnerable patient populations that we're taking care of. So as we sort of help Anna transition over, another important barrier and challenge that patients like her face is that our healthcare system, unfortunately, isn't adequately equipped to take care of these complex patients. So to put things in perspective, currently there are about 180,000 adults with congenital heart disease in Canada, and they encompass about 2/3 of the congenital population in Canada. There are only 15 ACHD centers taking care of them, Ottawa being one of them. And a pan-Canadian study done by Ottawa's own Dr. Beauchesne in 2012 showed that 80 cardiologists affiliated with an ACHD center, only 27% actually had formal ACHD training of 1 year or more, And an astounding less than 2% of all Canadian cardiologists actually received formal ACHD training in spite of this growing complex population. What's even more surprising is that only 23% of the Canadian ACHD population are followed in these tertiary ACHD clinics. Unfortunately, the ACHD care structure hasn't changed in the last decade. So this is data fresh off the press about a week ago that looks at 2020 survey data among all the ACHD Canadian centers. And you can see that in spite of a 68% increase in the patient volume in terms of number of patients with congenital heart disease, the number of ACHD trained cardiologists has only increased by 19%. In spite of this, and the people who are getting trained has only slightly increased compared to before. And in spite of having 10 years of work in ACHD, still only 20% of our ACHD population are actually followed in ACHD centers. Not only that, there's actually a profound need for allied health providers specialized in caring for these patients. So as you can see here, between the two pan-Canadian studies in 2007 and 22, we still haven't increased our allied health providers to care for these complex patients. So as you can see, only 2 out of 15 centers have psychologists or social workers dedicated to caring for these patients. And unfortunately, Ottawa is one of the centers who do not have these specialized providers. Studies have shown that congenital heart disease patients cared by ACHD specialists actually have better outcomes. This is an Australian study that showed that guideline deviations were actually more common in referrals from general cardiologists compared to ACHD trained cardiologists and were actually significantly related to increased adverse outcomes. Again, underscoring the importance of formal ACHD training in caring for our patients. And this finding was irrespective of the type of congenital heart disease or complexity of the congenital heart disease, once again highlighting the importance of delivering care by ACHD specialists who are trained in specialized centers to care for these complex patients. It is understandable why caring for these patients is challenging for our general cardiologists, because general cardiologists already face high volume of patients to take care of with acquired heart disease. They have limited training during their fellowships or exposure to congenital heart disease during their fellowships, limited access to advanced imaging and interventions, which these patients frequently need, and sometimes are overwhelmed by the volume of patients that they take care of, that they are unable to provide the time that the complex patients with congenital heart disease may require. So understanding the benefits of ACHD centers, the Canadian Cardiovascular Centre in 1998 actually recommended that all ACHD patients should be referred to specialized ACHD centers for ongoing care. And with this recommendation, there was a significant increase in the number of referrals to ACHD centers, as you can see here. And subsequently, we saw significant reduction in mortality among our patients as they were referred to specialized ACHD centers. Again, enforcing the importance of specialized centers to take care of them. And in 2022, the CCS actually updated their guidelines and recommendations saying that all ACHD patients should be seen by a specialized ACHD center at least once, even for hemodynamically insignificant small shunts, and the ACHD provider can decide who can be followed safely in the community versus needs tertiary center care. So sort of coming back to this challenge and barrier that patients like Anna face in their transition journey, which is inadequately equipped healthcare system to care for these patients, I hope that we can overcome it by investing more resources to equip and train healthcare providers, including physicians, nurses, and allied health workers, to ensure that all patients with ACHD are actually assessed and cared for in specialized centers at least once in their lifetime, and continued care for everyone else who has congenital heart disease that's not very simple, a simple defect. So sort of as we move on to the next sort of stage in Anna's transition journey, I've already partly introduced the next barrier that patients like Anna face. But I would like to highlight it again, which is the increased loss to follow-up and adverse outcomes that patients face during the transition period from pediatric to adulthood. So I've used the word transition quite a few times, but what does it truly mean in its essence? It's not just moving a patient from a pediatric care setting to an adult care setting, but it's actually a continuous process that starts in adolescence, usually at the age around 12, and extends into adulthood with the goal of successfully integrating the patient from pediatric care to adult care. And this usually includes transfer, which is a subcomponent of transition, where the patient's care is physically moved from a pediatric center to adult center. And this transfer process usually includes components like patient education, skill development, and gradual increase in independence among these patients. So more than 50% of the congenital heart disease patients are lost to follow-up during this vulnerable period of transition. And this is supported by data from Sick Kids in Toronto, where by age 22, only 47% of patients with congenital heart disease were being followed by a tertiary ACHD center. And since this transition period usually coincides with the honeymoon period that we talked about, where patients are feeling well and asymptomatic, we can see why patients can feel unmotivated to have continued follow-up when they're feeling well. And this loss to follow-up is further perpetuated by lack of awareness for need of ACHD care, even among our healthcare providers. For instance, a study from Quebec actually showed that even among those with severe congenital lesions, 21% were not seen by an ACHD provider by age 18. Whereas majority of them were still being followed by a primary care provider. This implies that referrals to ACHD cardiologists were probably not being made by the primary care providers, which is a missed opportunity for referrals due to the lack of general awareness among our general practitioners that there is a significant need to actually follow these patients in ACHD centers, even if they are asymptomatic and feeling well. And it is clear that lapse in ACHD care actually leads to negative outcomes. And there's a threefold increase in need for urgent surgery and catheterization when these patients are seen in ACHD care within 6 months of re-entering. So I've spoken to you about a lot of factors that sort of play in producing poor outcomes in transition, but there are many more factors that I haven't spoken about. The social and economic barriers that these patients face throughout their journey is significant and should not be ignored. But I would specifically like to focus on one of the factors, which is the delay in care that patients face during their transition period, during long wait times to be assessed by ACHD specialists because of limited resources and trained specialists that are available. So what are we seeing here at the University of Ottawa Heart Institute is we completed a retrospective study looking at patients who had their first ACHD appointment from June 2019 to November 2022. And we analyzed about 365 patients who were transferred from CHEO and the community, waiting to be assessed by an ACHD provider. And we found that there was around 10-month wait period for these patients to be seen by an ACHD provider in Ottawa after receiving a referral. And surprisingly, 13% did not have a family physician. And that's similar or on par with 15% of the Ontarians who do not have a family doctor. And majority of these patients were moderate complexity lesions who were referred from the community and CHEO. And we had 50-50 referrals from both sites. And we found that 13% of these patients, or 1 in 8 patients, actually had a decline in their health while they were waiting to be assessed by an ACHD provider. So that's in the form of emergency department visits specific for their heart condition, unplanned hospitalization, progressive cardiac symptoms, or needing an urgent intervention when they were seen in our ACHD clinics. And patients with moderate or greater complexity lesions actually had higher adverse outcomes compared to those with simple congenital lesions. Interestingly, there was no association with these adverse outcomes, whether the patient had a family doctor or not, and whether they were referred from a pediatric center or the community, which once again highlights the important fact that these patients are actually vulnerable and need timely and comprehensive assessments. So coming back to this barrier and challenge in Anna's journey about vulnerability and loss to follow-up, I hope that we can increase patient supports and timely follow-up during this vulnerable period to sort of take down this barrier for these patients. And the final barrier in Anna's journey that I wanted to discuss is the significant gap in patient knowledge surrounding their congenital heart disease. Because as you can understand, these patients are overwhelmed with the amount of information that is thrown at them, especially at a young age, when they are unable to comprehend medical system or medical illness. A study by Moons in 2001 showed that basic knowledge surrounding congenital heart disease among patients was only moderate and was actually even poor when we looked at the reasons for follow-up and alarm symptoms. Patients did not know when they should follow up, how they should follow up, or what types of symptoms is actually alarming that they need to seek care for. And what are we actually seeing in Ottawa? We actually did a prospective study of 115 patients who were transferred from CHIO and community centers and who had their first ACHD clinic appointment at the Ottawa Heart Institute from January 2023 to May 2024. And we saw, and these patients specifically were not enrolled in a transition program. They had a period of wait time to see a congenital specialist. And when they had their first appointment, we surveyed them to sort of understand how their wait period has been to see if there are potential gaps that we could address. And it was surprising that 1 in 10 patients actually did not know their congenital heart disease diagnosis at all. And almost half of these patients actually ranked their congenital heart disease knowledge as a score of 5 or less on a 10-point scale. Alarmingly, and this was extremely surprising, is that 78% of patients actually did not know how to contact the Heart Institute or the congenital clinic while they were waiting to see a specialist. So if they had symptoms or concerns, they would either go to the emergency department or their family doctor, but did not have a way of connecting to the tertiary provider who specialized in caring for them. And half of the patients who had been on the wait list described some level of emotional distress while waiting to see an ACHD specialist. And of them, more than 16% actually scored their emotional distress of 5 out of 10 or more. And noticeably, the most common worry among 43% of these patients was uncertainty surrounding the next steps of their cardiac care while they waited to see an ACHD specialist. And while waiting, 7% of the patients actually had emergency department visits, and 4% had unscheduled hospitalization related to their congenital heart disease, which could have been prevented if we had earlier connections with our patients. And in spite of all of this, we were pleasantly surprised to see that majority of these patients rated their quality of care as being good. So overall, this prospective study that we conducted highlighted to us the urgent need to have better support and education for patients in the process of transitioning either from a pediatric center or the community into adult care, especially those waiting to see a ACHD specialist while they are not connected to a primary cardiac provider. So this is the most vulnerable group that we can help. So going back to Anna's transition journey about the significant gap in patients' knowledge surrounding congenital heart disease care, I hope that we can overcome it with early and consistent patient education to empower patients like Anna to take charge of their care in the process of transition. So as you can see, a patient's transition journey isn't as straightforward as we would like it to be and is riddled with many barriers and challenges, and I've highlighted a few of them today. So we can make this transition journey a bit simpler and easier for our patients and healthcare providers by number one, promoting awareness that congenital heart disease encompasses the entirety of the patient's lifespan. It's not just a pediatric disease. Number two, creating awareness that most congenital heart disease are not cured. In fact, these patients are at increased risk of developing not only complications related to their congenital heart condition, but also acquired heart disease. Number three, reinforcing that all of these ACHD patients should be assessed by a specialized ACHD center at least once in their lifetime, and then continued follow-up for everyone other than simple congenital lesions. And for this, we need robust ACHD workforce and trained ACHD specialists, nurses, and allied health workers who are able to contribute to it. Number four is increasing patient support during the transition period to prevent lapse in care and negative outcomes. And finally, promoting early and consistent patient education to empower them to take care and take charge of their care. So this way we can help patients like Anna to make this transition a bit easier. So how are we helping as a group here in Ottawa? So in Ottawa, we've created a multi-pronged ACHD transition program in an attempt to address some of these gaps in transition among patients with congenital heart disease. And it's been set into motion since July 2024. And we specifically wanted to focus on the transition period where patients are waiting to be seen by an ACHD specialist after a referral that's made from CHIO or the community. So these are patients who are not primarily connected to a cardiac provider, which we have identified as being the most vulnerable period. And these patients are enrolled in the program as soon as the referral is received and has three main components to this program. So one is a ACHD nurse check-in at 1 month of receiving the referral. Two is creation of a quick glance diagnosis summary. And three is a second nurse check-in after 1 month of a physician appointment. So the first component, which is the first ACHD nurse check-in, which is done within 1 month of receiving the referral from CHIO or community, one of our ACHD nurses, like Carolyn, who's in the group, will have a online appointment through Epic, which usually lasts about 45 minutes to an hour, where they meet with the patient face to face. And the goal of this appointment is to establish a clinical relationship early and to screen those patients at risk of deteriorating. So this is the template that our nurses sort of follow during this appointment. And as you can see, there are different topics that our nurses are assessing. They're not only assessing the understanding about the patient's understanding about their cardiac condition, but they're actually actively teaching these patients with personalized diagrams from the University of Basel, like the one shown on the right here. And they're providing important teaching around healthy habits, exercise, but also cardiac specific teaching like endocarditis prophylaxis and activity limitation if it is pertinent to the patient. They're also screening patients at risk for deteriorating, including whether or not they have a family physician. Are they having any active symptoms? And if patients with symptoms are found, they're actually triaged to see a congenital specialist earlier than their anticipated follow-up. And remember the 78% of patients who did not know how to contact us? We make sure that we highlight our contact information, the way to get a hold of our ACHD nurses and ACHD physicians so that patients feel connected and heard of right from the get-go of the referral. And any other patient concerns or worries are addressed at this time. And this is happening within 1 month of receiving referrals from the community or the pediatric center. The second part of this multi-pronged ACHD transition program is creation of a quick glance diagnosis summary at the first nursing check-in, and it's uploaded on Epic. It's accessible both by the patient on MyChart on their phone and the healthcare providers, and contains concise and customized information for our patients. So this is sort of the summary and how it would look like, but it will be more electronic for our patients. It has a summary of the patient's congenital heart condition, interventions that they've had, whether they have a device, are they on anticoagulation, would they need a bubble filter if they were to show up in a merge to prevent embolism? Would they need endocarditis prophylaxis? What are the specific cardiac alarm symptoms that we would be worried about in this certain patient? And these information will be accessible both to healthcare providers and the patients. And the idea is that if a complex patient presents themselves to a community hospital in the emergency department who are unable to access the ACHD clinic notes, they can pull out their phone and show the emergency department provider, this is a summary of my diagnosis. These are the things that you need to know about me, and this is how you contact the clinic if you needed to speak to a specialist. So it's a line of communication where the patients feel secure and understand their disease sort of a perspective a bit better. And then finally, the third component is a second nursing visit designed so that nurses check in with the patient after the first appointment of the ACHD provider. And this appointment is mainly to consolidate information and to answer questions from our patients. This is a template of how it looks like on the second nursing visit, which is done 1 month after an appointment with an ACHD provider. And you can see that patients' cardiac knowledge about their congenital condition is reinforced. Once again, contact information as well as symptoms to look for, and any concerns are revisited among these patients. So will this be effective? We are currently in the process of assessing if this multi-pronged transition program that we've designed to see if it's actually going to make a difference and be impactful in our patients' lives. So far, the first 50 patients to receive intervention A and B, which is the first nurse check-in as well as the quick glance summary, have been completed. And we're in the process of enrolling our next 50 patients to add on the third intervention, which is a second nursing visit after the first ACHD clinic provider visit. And we're planning to assess the effectiveness of this program by assessing change in both patient-reported outcomes, for instance, through quality of life questionnaires, depression, anxiety scale, satisfaction with life surveys, but also to look at clinical outcomes like emergency department visits, hospitalizations, need for urgent interventions, to see if our ACHD transition program is actually tackling the problems to try and improve the adverse outcomes that we see in our patients. So it'll be done as 2 separate cohorts of first 50 patients to get the first 2 intervention, and the next 50 patients to get the 3 intervention altogether. So we've had positive outcomes so far. We've enrolled 98 patients so far, 47 from CHIO and the rest from the community. And all 98 patients have gone through in the process of the program or gone through the program. And we've already expedited 15 referrals to be seen by an ACHD provider earlier. So this might be symptomatic patients, pregnancy-related issues, patients needing urgent interventions. So I hope that we prevented some hospitalization or emergency department visit by triaging these patients and seeing them early and providing the much needed care that they need. And so far, we received quite remarkable comments from our patients about overall feeling connected to the care providers, but also feeling a bit more educated and having the contact information to reach out to the clinics if they have the need to do so. So overall, looking into the future, how do I envision this? Our colleagues at CHIO are already working hard preparing patients to transition from pediatrics to adulthood. But unfortunately, because of limited resources, there is no formal transition program at CHIO. In fact, many of the ACHD centers in Canada don't have a formal transition program. So I'm happy to say that we've sort of put the seeds to build a transition program here in Ottawa. And my hope is that if it is successful, we can extend it earlier and earlier for our patients to reach that optimal age of 12 years old so that transition can begin early and be more effective, and work together with SHIO in helping these patients throughout the most difficult part of their transition journey. So our vision, I would say, is that transition would start early, will involve their parents, but gradual earning of independence among our patients and constant education to create awareness about complications so we can identify patients early and give the patients the driving seat so they can feel in charge of their care and drive it forward, and we be a support system that they can fall behind so that they can feel supported and cared for throughout their transition journey, but also vulnerability. So an idea is just an idea without the people who work tirelessly behind it. So I'm incredibly thankful for all the hard work that people have done for this program. Especially a big thanks to Carolyn and Joanne Moran, who are our incredible nurses, who are the backbone of this program to make this possible. So thank you. And of course, Dr. Schwartzman and Dr. Burney for being throughout every step of the process, and Karen for helping with all the surveys, and all of our congenital cardiologists, Dr. Beauchesne, Dr. Chan, Dr. Phillip, and all of the internal medicine residents, Michael and Jamie, who actually helped with the process of making this transition program, move forward. So I appreciate all your time. Thank you, and I'm happy to answer any questions.
Thank you so much, Joanne. That was excellent. Congratulations on the work. It's a lot of work and well done. If there's any questions in the audience, please let us know, or you can put your questions in the chat box and we will answer. Dr. Golian.
Wonderful quality work. This is amazing, with what you guys have done. Wanted to challenge you on one question I had for you. Do you think that the ACHD clinic needs to be manned by specialty trained ACHD fellows? And the reason I ask is that you didn't show any data that, other than centralization and having high volume of patients seen at the same place by an interested person, that the outcomes would be different. Because you showed in Canada, what is it, 3% that have ACHD formal training, and the rest of the ACHD center is manned by, I guess, interested cardiologists that see a big volume of ACHD patients. I just wanted to see what your thoughts are on that. And, do we need to create a fellowship? That will take an extra year or so tacked onto a cardiology residency for training up.
Thank you for the excellent question, Dr. Golian. So I think the main issue right now, which I've struggled with a lot, is the availability of fellowship training in ACHD in Canada. In fact, I think there's only 1 or 2 programs that are funded to train ACHD cardiologists. So if you look at a cardiology training who's done 4 years of medical school, 3 years of internal medicine, 3 years of cardiology, who's anxious to go to the workforce to see patients, to move forward with their life, seeing another 2 years or 1 to 2 years of training that's unfunded and probably underpaid in the future when they become an ACHD specialist, it can be a turn-off point to many of our trainees. And I've seen and heard that from many people. And the barrier, one of the biggest barriers, is that these positions to train people interested in congenital heart disease remain unfunded. This is different from the US, where there are funded fellowship programs for trainees, whereas in Canada, trainees have to find their own sort of resource funding allocation to go there. So I think that's sort of the major barrier to start interest among trainees to go to an ACHD fellowship. If we had funded ACHD positions in all of the congenital centers, for example, Ottawa, we don't have a fellowship program. If we have funded ACHD fellowships in the 15 ACHD centers, I could foresee more people being interested and being willing to get the training that they would like to have. So I think the first step is to create funded position and get them accredited or board certified like the US. So training is a bit more accessible for cardiology trainees. And yeah, that's what I have to say.
Maybe if I can add my perspective, I think your point is well taken, and I agree. I think we have to expand training opportunities, and we have to create ACHD fellowships. And I hope it's just a question of time until we can also offer fellowships here in Ottawa. It's of course only also a question of the fellows need to have sufficient exposure to ACHD patients. So it's also a question of patient numbers. But I think now here in Ottawa, we have the size that we can actually provide sufficient training. It's now just the additional hurdles that we have to overcome. But I think that's definitely the next step.
Joanne, could you talk a little bit about the referral practice, for example, from CHEO? So are you getting the referral when the patient is, 16 or 17, or do you get the referral the moment they turn 18? And then you've got a 10-month delay after that. Do you see what I'm saying? Like, have those conversations happened with the community is a little different because you have, that's a population that you don't really know how much there is, or where they're going to come from. But for the patients that are followed, for example, in CHEO or sick kids, if you're in Toronto, wherever, does that transition begin in their 16, 17? Does the process start anticipating that it's going to take 10 months to see one of you folks? Or does it not really happen until they turn 18?
That's a great question. And if I misspeak, Dr. Schrotzman and Carolyn, please chime in. My understanding is that the referral is put in at the last appointment at CHEO, which is usually 17 or 18. But the problem is that they're not entered into the adult system till they turn 18, when EPIC becomes active. So it doesn't show up as an active referral till it's put into the system, is my understanding.
So we do get referrals when, like you said, it's their last CHEO appointment or foreseen CHEO appointment, which is typically 17 or just before they turn 18. And we have actually done a really good job at reducing our wait list since Dr. Schwarzman has been around. So the barrier to seeing Dr. Schwarzman is kind of no longer there, but we do respect the anticipated time of their next appointment based off of their CHEO schedule, if that makes any sense. So if they're 17 now, they're due to be seen when they're 18, we kind of just plan it around the same time. But yes, there is a slight EPIC issue where I cannot actually put in orders for testing until they physically turn 18. It's a weird thing.
Can we get that changed, Dr. Burney? No, I'm just wondering, like, if that's a hard barrier for your folks, right? That we can't do anything until a number changes in a computer system. That's a barrier that we can look at. Okay, so I think we're gonna look at that for you. Yeah, like if it's an EPIC hard stop, it's a barrier for you to do something. That certainly should be something that we should be able to look at. Let's look into that. I just don't want EPIC to be the barrier for whatever success you want to have. Okay, are there any other questions? Thank you so much, Joanne. That was excellent. And your slides are really well done.
Oh, thank
Have
you.
a good day.
You too.